I did a PubMed search for tibial fracture last week. It resulted in 13,229 hits, and if I added treatment, there were 10,273. If I then added fracture treatment and prospective randomized, I ended up with 139 hits. And then if I added level 1, it was 15. I know this is just rubbish, but I mean it's interesting figures. In Sweden, we have approximately 17 tibial fracture per 100,000 citizens per year. And a study by Jansson et al., they did a checkup for this and found that 48% were nailed, 27% were treated with plaster, and 12% were treated with external fixation. There is no Cochrane review about tibial fractures in the shaft. There's one coming up. And the objective of this review is to determine the effects of different methods and types of intramedullary nailing for treating tibial shaft fracture in adults. So they will look at reamed versus unreamed nailing, locked versus unlocked nailing, and titanium versus stainless steel nails. And they will not look into brace or plaster versus nail, plate versus nail, external fixator versus nail. So I tried to look at the literature to find if there is any evidence that we should use nail instead of plaster. So, is there any evidence? In 1991, Hooper et al. Did a prospective randomized study. They found a shorter healing time and less malunion in the nail group. Downing et al., 1997, found no difference in the cost for the society between plaster and nail, but they only had 39 patients. Bone et al., they did a retrospective study of 99 patients. There was shorter nailing time in the nail group and more non-unions in the plaster group. Wittenberg, they did a meta-analysis of paper published between 1966 and 1993. 19 papers were accepted. There were only one using nails. And the healing time was shorter in the ORIF group, one study was nail. Toivonen, 2000, did a retrospective study of 77 patients. They found that plaster treatment were more expensive for the society than nail. However, a lot more expensive for the hospitals. Kaladani, in 2000, did a prospective randomized study of 53 patients, and he found shorter healing time in the nail group. Toivonen did a retrospective study comparing nails and plaster, 25 patients in each group from a material of 210 patients. There was shorter healing time and sick leave in the nail group. So on the basis of these studies, there's supposed to be an opinion what we should use. I will come back to that. So is there any evidence about plate versus nail? Ganil et al. 2005 did a prospective randomized study of 78 patients. They looked at distal metaphyseal fractures. There were more wound complication in plate group, no difference between nail and plate regarding healing time, and no locked plate were used. So this is the same problem like when you look at the proximal femoral fracture. We have old and we have new implants. Tibial et al. 2005 did a retrospective study of 50 patients. There were more complication in the plate group. No difference was found between nail and plate regarding healing time. All nails were reamed, no locking plates were used. Jansen et al. 2007 did a retrospective study of 24 patients. No difference between nail and plate. No locking plates were used. Valier et al., 2008, retrospective study, 111 patients, shaft and distal metaphyseal fractures. They found delayed healing and malunion in the nail group. No locking plates were used. Lindvall, retrospective study, 72 patients, proximal fracture, shaft and metaphyseal. They used lock plates. They found no difference between nail and plate regarding healing time or complications. And finally, Gu et al. 2010 from China did a prospective randomized study of 111 patients. They all had distal metaphyseal fractures. More wound complication in the plate group, more pain in the nail group, and more hardware problem in the plate group. No difference between nail and plate regarding healing. So, what are the indications for plating? In the literature, proximal or distal fracture, intra-articular fracture component, proximal or distal, or converting an external fixator to an internal fixator. There is evidence that converting an external fixator to internal fixator could give us infection, even if we have a free interval which is very long. This was shown by Turnquist as early as 1990. So is there any evidence about nail versus external fixator? Tu et al. Prospective randomized study, 36 patients, open shaft fracture, all nails unreamed, non-union, malunion, malrotation, more common in external fixator group, higher infection rate in nail groups. This was not a Lizarro frame or just a single frame. Schandelmeyer et al., 1997, retrospective study, 32 out of 239, open shaft fracture, grade 3B. No difference between nail and external fixator regarding healing time or infection. Nail group made an earlier return to full weight bearing. All nails were unreamed. Shannon et al., retrospective study, 30 out of 102 open fracture. No difference between nail and external fixator regarding healing. All nails were unreamed. Bråten et al. From Norway, prospective randomized study, 78 patients, open and closed fractures. All nails were reamed. No difference between nail and external fixator regarding healing time or complication. More rotation deformities in nail group, more knee pain in nail group. Finally, Inan did a retrospective study of 71 patients, open and closed fractures, unreamed nail compared to Lizarro frame. More infection in external fixator group. Delayed healing, more common in nail group. More contracture in the external fixator group. So, what are the indications for external fixator then? I think open fracture, 3B and 3C, as a definitive treatment, not temporary, could be considered. Temporary fiction due to soft tissue, always. I think this is the most debated problems about tibial nailing. I think the debate has been a bit faded lately. Started with animal studies. Reaming damages intramedullary blood supply. But is this bad or is it good? This is just animal studies. Then we found out that reaming does not affect healing negatively. It is more complex mechanism than just circulation. There's no difference between reamed and unreamed nails regarding healing time, infection, non-union, or malunion. But this was open fracture, and in open fracture we would expect to find more negative effects of reaming. But this does not seem to be the case. Reaming results in shorter time to healing and has fewer hardware failures. Well, this is one of the largest, most expensive orthopedic studies performed, the SPRINT study, who Mo Bandari were the founder of, starter of. They had 1,226 patients, 600 in each group. And there were very little difference between reamed and unreamed, but there was perhaps in benefit for reaming. And finally, if you use an unreamed nail, you can't be sure you can put it down. Olin and Hammer in 1998 had 55 patients. They couldn't have the nail down for 10 patients. So the introduction of the unreamed nail is not the solution. The effects of reaming to lungs and intracranial pressure, that's another thing. We have to discuss that with the neurosurgeons and with the anesthesiologists. But minimal or sufficient reaming is probably better than no reaming. And there are, as you can see, some scientific support for this. BMP to open fracture. I think this is the second largest study in tibial fractures. 450 patients from 49 international centers. 50% of these patients were smokers. BMP affects bone healing positively, and infection grade were lower in the BMP group. And BMP reduces secondary interventions and needs for bone grafting. But this was open fracture grade 1, 2, 3B. And I'm not sure we're dealing with that many of those fractures if it comes to single surgeon. So most of this is level 6. Because when we do it now, this is level 7, perhaps. Closed fracture grade 3A. Use a reamed nail. 3B, consider external fixator and perhaps change to a nail within 3 weeks. After 3 weeks, then you should go with the external fixator. More distal, proximal shaft fracture. We don't have any scientific support for this, but I've said personal preferences. If you're a good nailer, nail it. If you're a good plater, plate it. Plater might be easier. And this is what we need to do. We need to do what the Americans did. Thank you.